Okay, so good morning and welcome to day 2. Today we are continuing our theme on looking at the fundamentals of biomechanics. And again, thanks to Jitendra and also the Gian initiative for making this course happen. So today being Tuesday the 18th, the day is focused on the musculoskeletal tissue, nominally divided up into two-hour sessions. We're going to cover about 4 hours across today. The sole focus will be on the musculoskeletal system and tissue that comprises that. As we discussed yesterday, the human body is pretty complex. We touched on the materials that are involved being viscoelastic, and so as a consequence they are quite complex tissues to try and understand. So we'll dedicate the majority of today trying to understand the ligaments, the tendons, the muscles, and the bones that comprise our human body. That will give us fundamentals then for tomorrow to go and apply that to the lower and upper limb, and also the head, neck, and spine, and then later in the week to see how we can enact some injury prevention by applying those principles. So we'll start today looking at bones. Bones are fundamentally the structures that provide the stability within the body. Needless to say that it doesn't take much to imagine what one would look like without bones. They give us the stability and indeed comprise our skeleton. Fundamentally, there are two different types of bone that exist within the body. We have an image here of the cross-section through a hip bone. So this is a ball in 3D. This is called the femoral head. And this bone is typically surrounded by the pelvis and the cup in which it fits. We have insertion sites here for ligaments and tendons to stabilize the hip. But the key thing here is to realize that we have solid white on the outer edge, and we have a less dense material within it. This gives rise to what we'd term either cortical or compact bone. That's the bone on the outside, or the material on the outside of the bone. The spongy appearance within the bone is what we call cancellous or trabecular bone. Porosity-wise, this is clearly pretty dense, has a porosity of 5 to 30%, or the inverse of that, the density is at about 95%. Density here is somewhere between 10 to 70%. The benefits of this is that it ensures that our bones are both strong and stable, but also as lightweight as possible. If these were entirely dense, then our skeletal system would clearly be a lot heavier than what it is, and that would have implications for the strength of our muscles and overall how we were to move. That characteristic of bones is replicated through the various different shapes and geometries of bone that we have throughout the body. Of interest is that a rat or other animals, where they have a bone that performs a similar function to a human bone, whilst the shape is clearly very different, if you were to cut through it and to size it relative to the human bone, their appearance would be quite similar. A strength and a weakness of bone is that the porosity is actually quite dynamic, and bones themselves are dynamic materials. They spend or they do remodel throughout life. This is a benefit because when you need your bones to become stronger, they can be. To detriment is that at times the bones become weaker when one doesn't want them to. Osteo meaning bone, and porosis, osteoporosis being a condition whereby the bones lose density, and if they lose density or increase porosity, then they inherently become weaker, and weaker bones leads to greater injury. The outside material of a bone is pretty much the hardest within the human body. Only the teeth and the dentin and enamel that make up the teeth are harder. And as I said, it's one of the most reactive and metabolically active materials in the human body, giving it rise both to modify its characteristics based on the loading that it's exposed to, but also to repair itself as well. Needless to say, those that are suffering bone fracture, without the ability for the bone to continue to regrow, then the ability of those fractures to heal as effectively as they do would be hindered. We describe this as a connective tissue. It is one of the tissues within the musculoskeletal system and within the body more widely that helps to bind our body together. But of interest to engineers is that there is a fluid and solid component to it. And this is where biomechanics becomes quite challenging. Were this purely to be solid, then one can imagine it as some kind of metallic foam, whereby the ability to predict how it behaves would be quite straightforward. It would be complex to model the geometry if one were to try and replicate that, but in a metallic format in finite element, for example. It would be difficult to get the precise geometry in position, but once the structure was in place, then it'd be a matter of simply applying the material characteristics to that structure, and you would be able to accurately replicate how it performs. The issue we have here is that there's not only the solid component of bone, but there's also a liquid within it as well. And so we suddenly become exposed to greater complexities of modeling, whereby we have a viscoelastic response that the material can derive. That people do take approaches to simplify it, to ignore the fluid, or indeed to look at strain rates that are quite consistent with what the body's exposed to. But modeling this is far more complicated than modeling an equivalent structure out of a typical engineering material. So we have our cortical bone, that's the bone on the outside. And that's the relatively stiff material. So that's a rather simplified version of a femur. So we have our femoral head. So this is surrounded by our hip. So that sits in our hip, and then yesterday we talked about how the knee is formed by the tibia. So the tibiofemoral joint. And this lot is the knee. So we have a femoral head, which is surrounded by articular cartilage. We discussed that briefly yesterday too. So we have articular cartilage on this surface here. We then have a long straight section. That's not a surprise to us because we know the structure of our bones ourselves. But within here is a void. So that is empty. Nothing in there in terms of structural content. But what we do see, which is quite clever, is an alignment of the structures here in much the way that were we to FE this structure and look at the principal stresses, we would see them demonstrated in our FE model. So we'll have a look shortly, but the small osteons, the small structures that make up the cancellous bone, actually align along the principal stresses. And in particular, this region here where the bone is the thinnest, the structures are thinnest, the microstructure of the bones are aligned specifically to ensure that it's as strong as possible for a smaller cross-section as possible. Down here, a similar thing happens. All of this is layered with strong cortical bone. Just enough cortical bone to give the function that is reasonable to expect, such that when we do walk, run, jump, our bones don't break. But this optimized structure is still vulnerable to injury. Typically in sporting environments, any kind of sideways loading, twisting loading to a certain extent, predisposes this bone to fracture. And we would see a fracture, if we're looking at a transverse impact, in a manner not dissimilar perhaps to this. So the bone is optimized for ensuring that the behaviors and the traits that humans want to use their body for are well catered for. So we're relatively fast at running because we have relatively light structures. However, when we get into a situation where the loading is exceeding what the bone is initially, or the loading is exceeded, and there would be failure. Of particular interest again is that the cortical bone on the outside it is very stiff, so that can withstand approximately 2% strain, whereas the cancellous bone inside it can go up to about 70% strain. So the cancellous bone inside about 70% strain. The gap in the middle, we call it the medullary canal, is home to bone marrow. And so that's where blood cells and other cells are derived from within the bone marrow. So we talk about the ability of bone to continue to replace itself, to remodel. About every 7 years, the skeleton is effectively a new skeleton. It's entirely replaced itself. The benefits of that is that it continues to adjust to your weight. And so clearly the bones of a baby are very different in terms of size and geometry to the bones of an adult. And so there's ability to continue to regrow and remodel are an important part of that. As a consequence of men being heavier and generally stronger, their bones are typically larger and heavier too. The skeleton is similar between male and female, apart from the predominant difference being in the pelvis of the female for childbirth. In total, there are 206 bones in the adult. That is a number that reduces from birth, predominantly as bones in the skull fuse together as a consequence of traveling through the birth canal. All of these bones are joined together. If you were just to have bones on their own, then you'd have a skeleton that has no structure at all. Indeed, if you were to look at an artificial skeleton, or indeed a skeleton that has been harvested from a human, there needs to be some kind of linkage between all the bones. If not, there is no chance of the bone or the skeleton resembling any sensible shape. And so these linkages are critical merely to a skeleton. If we were to replicate that through to a live person who has the loads and the forces that are exposed to them, as we discussed yesterday, then the need for the stability of the skeleton to be significant is quite clear. So it's the role of the muscles and the other soft tissues that we'll be describing later on today, and quite how they add value to the bones and the functional benefits of the bones that we can describe in such a basic form already. Without the other tissues as well, then the bones would be limited in their use. So babies have more bones than adults, and many fuse together to create or to derive the smaller number of bones that we end up with. And not only bones do they perform a structural role, but they also have a number of other capabilities as well. Thank you. They become a storehouse for minerals, calcium, for example. And as we've just said, this bone marrow, the bone marrow lives in the canal, the void in the middle of the two bones. The bone marrow forms red blood cells and white blood cells as well. Red blood cells are important. They carry oxygen in the blood. And so without red blood cells, the ability of blood to carry oxygen is greatly diminished, and there are a number of diseases that are affected by that. The role of white blood cells is to maintain a healthy level of bacteria, so to destroy bacteria that shouldn't be within the human body. To try and get some idea as to how much blood or how much work the bone marrow does, 10 to the 11 blood cells are produced each day. We can divide the skeleton into two. We have an axial skeleton and we have an appendicular skeleton as well. So the ability of bones to grow and to remodel is substantial. It's significant. Were that trait not to exist, then if we were to get into a situation where we have some kind of fracture, then the ability for us to repair it would be limited. Already, when we do have a circumstance such as this, where there is bone fracture, a typical response would be to wrap the bone in plaster cast. So we'd effectively be trying to stabilize that bone there. So we would immobilize all of that by wrapping it tightly together. In circumstances where the fracture is more significant than this, then you can look to apply a surgical intervention, and that might be putting a plate down the side of that bone and screwing it into place to stop there being movement between the two sections. This is to enable the work of osteoblasts in particular, where we need bones to heal themselves or to fix themselves. Then the osteoblasts need a particular environment in which to effectively achieve that. But on a more routine level, osteoblasts go around replacing the bone that's healthily living as it is. Longitudinal rates of growth, i.e. the bone getting longer and the person getting longer, are pretty well defined already. It's quite common to be able to plot. So on the x-axis, the years, so how old a person is, and then on the y-axis, their height. And so these growth curves exist. Certainly in the UK, they are quite an important tool in the early weeks of life, because there is an expected rate of growth. And if you start at so much height or so much weight, then after so many weeks, you're expected to be proportionately bigger again. And these trends have been established and exist. And they can be adopted even for your progression from infants to adulthood to predict how tall the person will become. And that the height is not something that someone has all that much control over. Clearly, if this was to be looking at mass, then these trends would be far weaker, because there's far more input that a person can have to influence their own mass. But in terms of height, the body effectively regulates the height you're going to be as a consequence of osteoblasts. The rate of bone remodeling and bone growth is not something that we can interfere with as such. So the length of growth, the longitudinal growth, that happens at a natural rate. And so that's to say that if at 5 years old you're so tall, then the likelihood is that at 15 years old you're going to follow that trend and be proportionally taller again. The thing that's interesting about bones, or one of the things that are interesting, is the ability of the transverse, so the width of the bone, the cross-section of the bone, to change. So whilst we can predict the change in length, what we can't do particularly well is to predict the cross-sectional change. And so there were pictures I saw in the lab yesterday. In essence, we can consider the cross-section of the femur to be a hollow tube. So that's pretty much taking a section from here. So there's our medullary canal. So that's got the bone marrow in, which is the red and white blood cells. Here is our cross-section of bone, and we have a very thin outer rim of cortical bone, and the rest is cancellous. But what we're saying is that this width is something that isn't really pre-programmed by the body. So these trends here don't really hold true for width. And the reason for that is because the bone width is the way that the bone has of influencing its own strength. And so if you spend significant time down the gym and you are generally stronger than the average person, if you eat more than the average person, so are a lot heavier than one would expect, then the bone changes as a consequence. And this width would go up. There aren't all that many examples where there's a dramatic decrease in the load or the force that goes through these bones. One example is in zero gravity. Where astronauts come back from space, their bones are known to be weaker than when they went. To the extent that those who have been, for example, to the International Space Station and have spent prolonged periods of time there, they are typically carried out of the capsule as it returns to Earth. Another consequence, and we'll consider this at a later point, is that if we were to try and see through this mess on the board, but there is, in essence, this blue structure that's been added to the bone when it fractures. The blue structure is a metallic plate. If you can't wrap the bone in plaster and fix it, or be confident that's an effective way of fixing it, i.e. if it's a severe fracture within the bone, then a surgeon may open up the leg and may screw the bits of bone back together again. And extrapolating back to a mechanical engineering scenario where you have a significant failure in a component, then rather than just trying to weld it back together or sellotape it back together, you need to have some kind of mechanical intervention to get the stability that you're after. So here we're saying that just by wrapping some tape around it, in essence, and letting the bone heal, where that's not sufficient to achieve the stability you want, then by applying a mechanical intervention of a plate, you can strengthen it together again. The downside of that is that you're in a situation that's not dissimilar to zero gravity. That is that there's little load going through the bone because your metallic construct on the right-hand side of this picture is instead taking that load. So this is a consequence called stress shielding. So that is that we have our metallic plate that can be used to secure our fracture into place, our quite severe fracture. And the benefit of that is that the bones won't move relative to each other. That's what we're aspiring to do. But the consequence of having some metal and some screws that are attached to the bone to stabilize it is that it actually takes some of the load out of the bone and instead is transferred via the metal plate. So whilst you're not walking in zero gravity, the strain and the load experienced by the bone is not hugely dissimilar to that. and as a consequence, the bone starts to remodel. The bone becomes thinner because it's not being exposed to the loads that it normally does become exposed to. This means that our bone becomes weaker immediately under the plate. And if we were to try and zoom in, so that's our cortical bone. And here's our plate, do it in black this time, that is screwed into the cortical bone. And we have some kind of fracture here. Then what we're saying is that over time, the thickness of this cortical bone will reduce because the plate is in the way still, taking some of the load. And at the very edges of the plates, you're going to have an increased risk of fracture. The bone won't refracture underneath the plate because the plate is holding it together. But where you have this relatively weak bone kind of stopping there, so this area is relatively weak, and then you have relatively strong bone starting here, we end up again with a stress concentration. So much like yesterday where we talked about ligaments and tendons attaching to bone, where we had a relatively flexible structure attached to a relatively stiff structure, here we're in a situation that's not dissimilar. And so in these regions, it's not uncommon to get what we call a periprosthetic fracture. And again, we'll talk about these in more detail later in the week. But a periprosthetic fracture is a fracture that happens just outside of the margins of the implant or the prosthesis that we've included. And so the remodeling of bone is hugely advantageous because it means when we do injure ourselves, it repairs. When we do expect to grow, then our bones grow. Where we do get stronger or heavier, our bones respond to that as well. But the downside is not that many of us are going to go into zero gravity environments, but the periprosthetic fracture risk is one that's real and is particularly a concern as you get older. Very quickly touching on this and trying to reuse this picture again. So if we get rid of our previous, in fact, there we are. So there's our femur being reinstated. In circumstances where we remove our femoral head and we replace our femoral head with a metal one, this metal one typically has a stem that extends into what was the intermedullary canal. So again, we have an issue where we have a metallic stem, typically. So we have metallic stem in bone, and so we have this transition from a very stiff metal stem through to the flexible bone again. And the issue with that is that we have this transition from the two different materials, putting people at risk of periprosthetic fracture. And so bone remodeling is hugely advantageous, but it comes with risk as well. Any questions on that before we move on? Nope. Let's have a look at this slide, and it might answer that question. If it doesn't, then we'll come back to it. So the question was, what type of loading is the bone typically subjected to? And as a consequence, where do injuries normally happen? On the top right gives us an indication of the types of loading that the bones can be exposed to. hard to imagine an example where there's purely tension. Unless you're hanging upside down, or maybe in your arms when you're hanging from some playground equipment or some kind of climbing activity, then there would be some kind of tension perhaps in the bones. Compression is more obvious as you walk or do most things. Indeed, torsion as well. We talk about the unknown internal and external rotation in the knee, and so it's quite easy to imagine how our bones at times are exposed to torsion. Shear is less common. Shear typically happens during sport and is not a hugely desirable load to have the bones exposed to. Bending happens quite commonly as you stand because of the distance of your femoral head, or the displacement of your femoral head from the knee joint. There is some natural bending in the femur as well. But more commonly is that you get a combination of all these loading activities happening at the same time. Which is the most injurious? It would be difficult to kind of pinpoint any that are particularly more likely to cause injury than others. The injury determines or depends on a number of external factors, one of which is the speed at which that external load is applied. So we talk again about the viscoelastic response of these materials. Bones behave very differently if you apply a load slowly to them than if you apply a load quickly to them. That combined with the ability of the bone to be different geometries in people who are apparently the same height, and also the different types of conditions that you might find yourself in. There's not one that would be particularly injurious over another. One person can become injured in a scenario whereby several other people have become or have not been injured. Equally, people may hurt themselves in a scenario where that they've done many times over and not hurt themselves. And so it's difficult to pinpoint one thing that is a particular cause of injury. The one thing that is problematic is this reduction in porosity. So we've said about how the osteons of the femoral head, and particularly the femoral neck, this is the really thin part that's vulnerable to fracture, particularly in the elderly. And it's vulnerable to fracture in the elderly because of this consequence. So this is a schematic of the bone, the trabecular bone in kind of adulthood. When you're fit and healthy, there is a relatively thick wall in each of these osteons. So you can see the osteons within this vertebral body here. So these are relatively thick. As we get older, the natural consequences for our walls of our osteons, and so that's within the cortical bone, within something like the femoral head, and in particular the femoral neck, the microstructure becomes thinner. And so as a consequence, the density of our bone reduces, or the flip side is the porosity increases. So from your 30s until, if you do have the good fortune to extend to your 90s, our bone reduces. And it's not just the cancellous bones and the osteons of the cancellous bones. It's also the cortical bone as well. And that's the outside bone that is, in essence, the mechanical, that takes the proportion of the mechanical load, or a high proportion of the mechanical load. And so where we have the microstructure of both areas of bone starting to reduce, then it's perhaps not hugely surprising that the risk of injury or fracture increases. And that's particularly acute in females. Postmenopausal females are known to be at far greater risk of bone fracture than any other kind of person within our typical demographic. And it's this part here, of no surprise to engineers at all. We have our load coming through our hip, and we have our reaction force effectively coming up the main stem of our bone. And a biomechanical engineer or not, I'm sure that one would hazard a guess at this area being the risk of fracture. It won't fracture as someone is walking along, but typically as a consequence of a fall where you have an unusual loading condition. So we talked about just a minute ago the picture at the top right, where we have twisting and shear happening. When someone's to fall over, then it could be that the bottom of the leg moves in a different way. And so you have tension, for example, at the top, and that may cause fracture. And so if we were to look at the statistics of femoral neck fracture, then we would be sure to see that elderly females lead that group of people, that group of patients. And it's because of this. It's because with age, our bones become thinner and as a consequence weaker. And going back to the question again, a lady who falls over in her 20s versus that exact replica of a fall in her 70s, 80s, and 90s, the risk of injury is going to be far greater as she gets older, directly as a consequence of this. It would be reasonable to say that the muscle bulk would be less as well, that the tendons might be slightly different in terms of their behavior too, but the predominant risk or the predominant cause of bone fracture is a consequence of this. The problem is that your relatively weak, relatively vulnerable patients, as soon as you have a fracture of the femoral head, that requires pretty much instant surgery where we take off the original femoral head and we put in one of these blue replacements. That then starts exposing you to other risks as well, periprosthetic fracture. So we're dealing with an environment, an engineering environment that is not optimal because you have this transition from stiff to weak, compounded by the fact the bone is weaker than normal anyway. And so you've got this transition from stiff metallic component to very weak bone because of this osteoporosis. Given that hip and knees and other implants were first investigated 40, 50, 60 years ago en masse, up to 100 years ago when you look at the kind of maverick surgeons who started dabbling in this area, then it's perhaps no surprise to appreciate that engineers have cottoned on to this problem. They know that this is a problem. And so the designs of the stems in particular of hip implants, and to a lesser extent knees, have been tailored to try where possible to mitigate against this risk. So you would see bone femoral stems that taper, that become thinner at the end. So you can reduce the difference between the stiffness of the metallic component and the surrounding bone. You can have bones that encourage, stems that encourage bone growth. And so again, you can maximize the transition between bone and metal. So you can have a combination of bone and metal as you move towards the stiffer head. But this is a problem, and a problem that to a certain extent remains unsolved, and the periprosthetic fracture is a real risk. And we can see this is a part of the spine, towards the base of the spine, and it's a scan trying to map the relative density of bone. On the left-hand side, 42, so that's already starting to reduce its density, so the porosity is increasing. There's no real need for me to comment on the differences between that picture on the left and on the right-hand side of an 84-year-old. So double the age, and the porosity of that bone increases dramatically. And we can see that where you do have an increase in porosity, so where you get to later years and the porosity has gone up, then to compound matters, there's not a linear relationship with the stress required to failure. So as soon as you start to get some loss of bone density, i.e. the porosity increases, you get a significant drop in its ability to withstand stress. So to a certain extent, the slide previously, whilst this looks an extreme scenario, mechanically the extreme scenario is far more subtle, where you're moving from point 1 towards point 2 porosity, and you've got a step change in how the mechanical behavior of the vertebra or any other bone behaves. Of interest as well is that there are similar trends that happen throughout animals. Not that that necessarily means that we have any greater interest in looking at cow bone, for example. There's not going to be a massive rush to increase the ability of managing osteoporosis in cows. But what it does mean is that these models become a scientifically valid approach for looking at osteoporosis as well. What we do see, of course, where there is value in understanding animal behavior more greatly in the horse industry, there's nothing you can do about it. You might know it's happening, but to all intents and purposes, osteoporosis remains an irreversible condition. The consequence of getting osteoporosis in the spine is different than in the legs. We have a normal cross-section of our vertebrae where it enables someone to have an upright posture. As we imagine the bone density decreasing, so as we imagine we end up in this scenario on the right-hand side, where you have consequential loading or where there is load applied from the top of the spine, as in this instance, you actually end up with the vertebrae collapsing on themselves. As they collapse, you can see the shape and the posture of the person changes, and so it means that the deeper surfaces, if I can hold that still enough, the deeper surfaces become exposed to greater stress because the load has been non-uniformly distributed, and so the risk of this increases further still. And so you end up with a cascade of injury beginning to be initiated, that as soon as one of these vertebrae collapses, the loading, when the spine is nice and straight, is fairly even from one vertebra to another. If you start some of these vertebral bodies collapsing, then you end up with the inner rim of these vertebral bodies having a greater loading than they're designed to withstand. Again, applying basic engineering theory, where you have a greater loading than a component is originally designed to withstand, then there is a risk of failure. And that's what we see here. We see vertebral bodies on the rim that's kind of deepest becoming more compressed. And that can lead to all sorts of things. Here we've got a wedge fracture that we can see here. The consequence of these aren't good. You don't want to be in that position. And the last slide of this section, again, demonstrates the consequence. So you have these failures within the deepest edge of the vertebral bodies. Where you have that change, you have a change in the overall height of the structure. That means that your center of mass is moving forwards, so that has consequences to the lower limbs and the pelvis. Fundamentally, you become shorter, and so you might see people who are elderly being fundamentally shorter than what you imagine them or remember them to be, and that could be a real consequence of this. But it's mainly, from our point of view, the biomechanics. You have the change in loading patterns from the optimal, which is this, to a concentration of load on the inner surfaces, which is the exact thing you don't want to happen as the bones become weaker. And there's also the consequence of what happens further down the body. So that the concept of the body being a chain of events, where you have something happening at the top, it's going to have an influence on what happens down the bottom as well. Any question on bones at this stage?
I think that makes the bone more brittle. But in men it has been observed. I recall.
So the stiffness of the bones?
Yeah, it is going to increase with age for men.
Yeah, where you have stiffness, then you're likely to get an increased risk of fracture.
Yeah,
Yes, brittle fracture, that too. Okay, I propose that we have a few minute break, and then afterwards it will be the fundamentals of joint biomechanics.